So, ladies and gentlemen, my name is Sharon Whiteman, and it's my great pleasure and privilege to be bringing another amazing interview in this series that we started in late 2019. I know some of you will be watching this this week in 2020, and some of you will be seeing this down the track. Now, today our guest is Dr. Harris, Dr. Stephen Harris from California. He's a medical doctor, board certified in family practice. Since 2001, Dr. Harris, the primary focus of his practice has been on the diagnosis and treatment of chronic and complex illness, including Lyme disease, other tick-borne co-infections, as well as myalgic encephalomyelitis, chronic fatigue syndrome, fibromyalgia, autistic spectrum disorder, chronic inflammatory response syndrome, mold, mycotoxin, and other environmental illnesses. In his approach to these conditions, he incorporates strategies found in conventional, functional, and complementary medicine. He believes that there are many effective treatments available to those with chronic and persistent infections. Dr. Harris has taken a leadership role in LymeDisease.org, a research patient advocate group, which has been largely responsible for spearheading favorable legislation protecting patients, expanding Lyme disease awareness, and fostering continued public health education. Dr. Harris is also an active member of ELADS, the International Lyme and Associated Diseases Society. It's a professional medical society of physicians and scientists, which has become the authority on effective and evidence-based treatment for chronic Lyme and associated diseases. So, Dr. Harris, I know you're extremely busy, and I'm very appreciative that you're giving those of us in Australia who are ultimately medically abandoned some of your time today.
Thank you.
So, Dr. Harris, tell us a bit about your background and why you became interested in sort of complex. I mean, I'm a former critical care nurse, and I was a critical care nurse for 20 years, and I've worked with all kinds of doctors, and doctors that work with chronic illness. You're almost like investigative scientists, I think. You know, you have to be patient and really listen to the patients, and it's a real unique and very precious skill. So how did you get down that line of work?
Well, I spent quite a bit of time during residency in my medical training actually doing surgery, and was very involved and interested in trauma surgery and wartime medical assistance. And so I expected that I was going to be, after working in the United States for a couple of years, spending most of my time, whether it was with Doctors Without Borders or another organization or on my own internationally, really planned on doing jungle medicine, as it were. And so I started, after training, I started working with Dr. Therese Yang in San Diego just to get my feet wet. And she was one of the clients, actually, of my father's lab at the time. He started a lab, IGenics. And so I knew quite a bit about Lyme disease and about the plight of patients, and was very interested in Lyme disease, and but didn't expect that I would actually be practicing in it until I started working with Dr. Yang and realized in East San Diego County that it was essentially jungle medicine, what we were practicing. These patients were some of the sickest that I had ever seen. They had been undiagnosed for years. They suffered neurologic disorders, musculoskeletal disorders, the fatigue and pain unlike anything that I had ever seen in my training. And when I saw that there was such an unmet need in this country, I decided to really focus on Lyme disease, since I had already had such an extensive background. I had many nights talking over the dinner table with my father about the plight of Lyme disease patients, about diagnostic testing, about their inability to get diagnosed, and then when they were diagnosed, that they weren't getting treated, they were ignored, they were maligned, and it was very heartfelt hearing about these patients. And so as I started to initiate my own medical career, it seemed that it was the natural thing to do.
Wow. So like quite social justice and human rights drive right from the very beginning.
Well, it was these patients they weren't getting care that they needed, and there was answers for these patients, for most of these patients. We didn't have the extensive knowledge of complementary medicine that we're developing now, and there was very few treatments that were available, but many of the treatments really worked. And so if there was a treatment that worked for most of these folks and they weren't being delivered this care, it just was natural that they should be able to receive it.
Fantastic. So your father must have been a pioneer like yourself.
I think he's definitely one of the pioneers. He and Richard Horowitz and Joe Barascano and John Druhl and so many others, and Therese Yang. And so the new generation of docs at the turn of the century, we're just standing on their shoulders, basically, and we're able to springboard from their courage and innovation to take from where they left off.
That's so fantastic. So much need is, there's no fear in innovation. Sometimes I look at what happened in Australia and the medicine in its place of status quo is frightened of innovation. And it's, I don't know what that is about. What drives you through those challenges of medical and health policy failures that you see?
Well, knowing that these folks can get better, knowing that the answer is there, and knowing that if we can hold fast to what we know is true and right and be open to learning new information when it comes in, it's really being open and being steadfast at the same time.
One of the things is that it's science-based, isn't it? You know, like really the denial is based on cherry picking or historical or old, outdated science.
Well, that's part of it, but there's also probably some deeper and more sinister reasons why it's being denied. I like to think that it's being denied because some of the rule makers are either blind, stupid, or they're lying. And at the same time, yes, they can cherry pick very limited studies, and at the end of the day, we don't know how the pathogenesis of this disease affects everybody because there's so broad scope of symptoms that it does baffle the mind about how these patients could be so sick. And when there's so many systems at play and that you're crossing so many disciplines, that when, at least in the States where we have such subspecialized medicine, where doctors don't really talk to each other and we don't have broad generalized treating physicians that can look at both evidence-based medicine, and then when the evidence is yet to be forthcoming, look at possible and patient-oriented medicine. It's quite a phenomenon, and I think it's really an approach based on our medical system. It doesn't really allow for integrative care of chronic complex patients. Whether it's because of the subspecialization, whether it's because the lack of information or the partial information, or some people at the top withholding all the information that they know, because it's not all bad apples out there. Most of the doctors who are denying care, they're not bad doctors necessarily. They're listening to the textbooks and they're listening to some of the so-called experts. It's a few bad apples. It's like the dirty dozen. But when the docs who are, and the researchers who are getting refused entry into the top journals just based on their name, regardless of how good the evidence is and how good and clean the studies are, and it becomes so politicized that it's really hard in the space of multi-truthisms for these good doctors to really know how to take care of patients when they're hearing so much information from the other side.
Wow. And there, so you talk about the lack of there is still a knowledge gap. And in medicine, there's other diseases where their causality isn't proven and they don't know what causes something, but they still get medical care. What can you comment on that?
Well, most of medicine is that, and that's why it's the art of medicine, or the practice of medicine. The true knowledge of medicine really is in the realm of surgery for the most part. because much of the time we don't know what we're doing. We don't know why anesthesia works. For example, anesthesia still happens. Multiple sclerosis, Lou Gehrig's disease, Parkinson's disease, dementia. We know what happens, but we don't know why it happens. These people are not being denied care. There's studies, there's experimental treatments that are always being done for these folks. In fact, all autoimmune diseases aren't really understood. Why does the body turn? We know that there's genetics and epigenetics and environmental factors, but each person has their own story from the genetic to the other causal factors. And so it's really quite astonishing that in the face of a disease where we know one of the pathogenic agents, such as Borrelia, that causes Lyme in these patients, whether or not it's an active infection or a dormant infection or a hyperimmune or then autoimmune infection, these patients are not being treated in any capacity.
Mm. And what do you think the solution is to the problem, like the impact of this medical and health policy denial? What do you think is the solution, and what do you think the impact is on patients?
Well, I think it has to be multi-pronged. I think that the science needs to continue. I think that that governmental action needs to continue and needs to have broad perspectives. I think that that stakeholders of all kinds need to have a say. I think that that funding needs to continue and that incorporates many different viewpoints, not just that's an autoimmune or psychiatric condition. I think that, unfortunately, though, I think that much needs to be done like was done for HIV/AIDS, that it has to be also a patient advocate-driven movement. It often is, and it often is the patients and their loved ones who are driving this. We still don't have a Magic Johnson, for example, who really turned the whole HIV/AIDS movement and brought so much funding and so much recognition to the disease. And we've had some amazing advocates who have made such a difference, and we need more of that.
Absolutely, absolutely. And so while this politicization is impacting healthcare, what is the burden of disease impact on patients who, in Australia right now, it's average 10 years to diagnosis, our survey shows. What is the impact for patients' quality of life and their potential outcome back to, high quality of life for full recovery?
Well, the longer one goes sick, the harder it is to get them better, for them to get better, because it becomes the infection at the root, but then it's also all the damage that the infection caused, the metabolic changes that happen, the epigenetic changes that happen, the body burden, the organ fatigue, the cellular and mitochondrial damage that happens becomes so extensive over time, the adrenal fatigue, the cardiac exhaustion. All of these things happen, not to mention the loss of relationships, the loss of dignity of patients, the fear, the post-traumatic stress, which becomes really part of almost everybody's disease story. Because most people, whether it's denial from their doctors or disbelief by loved ones and friends, or loss of community, not to mention the financial burden that goes on from being undiagnosed, and then when you get diagnosed, the exorbitant treatment, because we do know that when these patients come in after 10 years, that antibiotics by themselves don't often do the trick, as it were. One needs a very broad approach. We need to right the hormonal changes. We need to help support the metabolic changes. We need to do, in my experience, a tremendous amount of integrative care. There's so many health systems that are outside of allopathic medicine that have been used for hundreds or thousands of years that offer so much support for these folks, and bringing these patients to these practitioners is expensive and unbelievably difficult. And so putting very complex plans together is quite a tremendous work on both the patient and the provider's part.
And you spoke, or your introduction, you focus on complementary medicine and functional medicine. What aspects of medicine do you bring together, and can you explain? Because there's lots of people in Australia actually that don't have any treatment. I'm one of them. I've stumbled along through multiple weird and strange things to get me back to quality of life. And the losses that you describe of the life as you know it is, describes so many of us, myself included. So what kind of, you're looking at, obviously typical or stereotypical modern or Western medicine, functional medicine, and integrative or complementary medicine. Can you describe those or expand on those for people who possibly haven't had exposure?
Sure. So there's allopathic medicine, which is primarily there's a problem, and then you use a chemical agent to fix the problem, either to reverse the problem, to attack the problem, and very rarely to support the problem. And so that's your typical Western medicine, where there's studies that are double-blinded, evidence-based studies that prove that one agent being used will help somebody more than the agent not being used, or than a placebo being used. And that's great when it works. There's some really exciting things that are happening with certain new medications against the agents, et cetera, and that's fabulous. However, for many of these patients, these chronic conditions, it's not just the agent that's causing the problem, and Western medicine doesn't address that. And so in that situation, we have to use herbal medicine oftentimes. We have to use other kinds of body modalities, whether it's a neuroplasticity retraining, meaning to help the brain relearn things through, sometimes you can use electricity or electromagnetic devices. There's quite a bit of research in the neurology field about this. There's other body modalities that are much older, such as Ayurvedic medicine, which is an old Indian form of medicine. There's traditional Chinese medicine that uses herbs based on a whole different paradigm. That also uses things such as acupressure or acupuncture. There's different kinds of massage. There's different kinds of meditation. Of course, meditation can be amazing for helping to connect the body and the mind, to take away that stress response that illness seems to cause or does cause. There's various kinds of light therapy. There's Maori forms of healing that are deep, very, very deep tissue massage that aligns the body in different kinds of ways. There's Feldenkrais, there's Rolfing, there's somatic experiencing, all these different things to help balance the body, that when it's fighting something, that it helps the body not have to fight so hard. Because one of the problems is, one of the reasons patients are so sick, yes, it's the spirochete, or yes, it's the co-infections or the agent in question, but it's also how the body responds to fighting this infection. And what happens is that we build up so many defenses to try to attack this organism, and we do it inefficiently. And as a result, we create sometimes more problems than were there initially. And so when people have pain and when they have nervous system issues, it's not necessarily a direct attack by the organism all the time. It's our body's response to that. And so Western medicine doesn't usually address those forms. And so we need other forms of treatment, whether it's German biological medicine, or homeopathy, isopathy, and other forms of medicine like that can be remarkably useful.
It's so amazing that you brought up the term artistry in medicine, because I was obviously very allopathically trained, and that's critical care is the area that we do a fairly good job in modern medicine. But my last nursing job I was a nursing unit manager of a chronic fatigue clinic. And I worked with amazing minds in that clinic, medical minds. And, they brought up that, medicine is an art, and it needs to be flexible. It needs to be moving with the patient, and need to have that open and innovative mind and approach to it, because we don't know everything. So Dr. Harris, one of your patients, Natalie, I'll just use her first name, has wanted to highlight, we talked about the delay and the burden of disease when someone's had a real delay. And Natalie's fairly unique in Australia in that she's recognized by her work cover insurance as contracting Borrelia burgdorferi, the North American strain, at her work. She worked as a Busher-Jenner Parks warden. And she's very medically fragile right now. We're working really hard to get her medical care in Australia. And right now we're up against so many blocks. So what happens when that effective medicine hasn't hit the mark to date, or when people are denied that? Natalie's has so many systems involved now. And, we're really needing to advocate for her for some of the treatments that she was able to attain from you in California that, when they're removed, she's sliding backwards again, and she had that hope and joy and improved well-being. Can you comment on that?
Yeah, so Natalie is an interesting, very interesting individual, and what you find with some people, for example, not necessarily Natalie first, is that people become very reactive to any treatment. And so even using a very small amount of a medicine or an herb or another agent, the body becomes remarkably reactive. And there's some new theories about that. Bob Nabio talks about the cell danger response. We know about the stress response. We know about, and now we know about mast cell activation syndrome and all of its associated issues. And so many patients we have to approach very, very delicately. We have to kind of almost do a dance with the body to get the body to actually receive some of the treatments that are good for it. Because the body begins to look at everything as a threat. And so you almost have to go around the body's awareness and for it to receive the right treatment. So sometimes we can use things to help modulate that response. We can use gamma globulin, which is immune globulin from donors, and sometimes we can use other modalities such as plasma exchange pheresis or apheresis, where we pull out some of the antibodies or some of the waste products in the body. Sometimes we can use membrane exchange protocols using things like lipids, intralipid or phosphatidylcholine, to try to get the body to respond. And then once we get to that certain area, then we can usually move in and address the various infections. When someone like Natalie, who has a whole host of infections and co-infections, maybe Lyme is at the core of it, we have to sometimes work on one at a time and then initiate another one. It's curious because many of these organisms, they almost, even though the symptoms are protean and each organism can cause so many symptoms, sometimes as part of the treatment, maybe we'll start treatment for Lyme disease, and then all of a sudden symptoms will change, and they'll be primarily, let's say, shortness of breath and air hunger and headaches and more nervous system issues, and then we'll treat for Babesia, or one of these red blood cell parasites, and then the symptoms will change again, and so the symptoms morph a lot. So the treatment can be long because we can't safely use 7 or 8 antimicrobial agents at one time. The beauty of Natalie's course is that when she gets the right treatment, she feels it fairly quickly that it's the right thing for her. And so it's, and she's been able to, over time, tolerate, well, if it's the right treatment, she can tolerate quite heavy treatment, and it does work, but it doesn't continue to work if we can't do it long enough. And sometimes we are lacking in the right agents, and the cost of some of these new medications is just so exorbitant. We need time to be able to learn that dance with each person. And it's just not reasonable for someone to come to the United States and be treated for 9 to 12 months, which is what she would need to hopefully recover. She recovered the first time, and then she was unable to continue treatment, and then suffered for several years after that, and then came back and was unbelievably sick. And so we were slowly able to start bringing her out, and then she couldn't stay. And it's just, she needs to continue treatment in Australia, and we need the docs, and we need the insurance, and we need the nation to rally to support her.
Absolutely. And is it correct to say that for some people that extensive or long-term disease can result in a secondary autoimmune response from?
Can. And it's whether it's from the same kind of concept as a cell danger response, or like a mast cell activation, that's a primarily not completely histamine based, but yes, there's definitely an autoimmune that has antibodies, or that we have that we have our body attacking ourselves through a whole bunch of different mechanisms. And I think that we're slowly beginning to understand how we can do this in a safe way. So many of these so-called biomodulators, biologic drugs, they're immunosuppressive. And so if someone has a very active infection and you use these immunosuppressives, they can be devastating. I've seen people die in this situation. It's just horrible, where people have used tumor necrosis factor, alpha blockers, and things like that in the face of a very active infection. And so while that mechanism, even though tumor necrosis factor as a chemical, is one of the things that causes so much pain and suffering, we can't just block it directly like that. So while there's so much controversy and so much infighting between those practitioners who think that this is an active infection alone, and so many others who think that it's an autoimmune alone, I think that there is a place for common ground where we can utilize many of these biologics, whether they're pharmaceuticals or a more natural approach to deal with the autoimmunity. Because if it is autoimmunity or hyperimmunity, which is probably more what is actually the case, that the body's trying to do the right thing in a sense, but it can't find the bugs, or it doesn't have the right armamentarium to kill the bugs, and so it uses over exuberant strategies, and in so doing causes damage to the body, whether it's through antibodies or whether it's through other forms of cellular killing. It's a response to try to address the infection. And so you don't just want to dampen that completely. You want to find a way to get the body to work more efficiently, to modulate the immune response, not suppress or destroy the immune response.
Natalie also wanted me to ask you to highlight about ketamine and its usefulness in some situations.
So ketamine is an interesting drug. It's been used in the the veterinary world for quite a long time for anesthesia. It's also been used in anesthesia in a limited way in adults and children, for that matter too. It's been the subject of a Time magazine cover a few years ago as a novel treatment for depression, and it's an amazing treatment for depression. It's an NMDA receptor antagonist, and it can almost reset how the body experiences stimuli, is the way that we look at it. And it can be quite a dissociative, not quite hallucinogenic, but more a dissociative drug. So it can be quite fear-inspiring for some people, but there's definitely ways that anesthesiologists and other practitioners who utilize ketamine can make it less intimidating and less troubling to ingest. It can be used as an IV form. It can be used orally, sublingually, nasally, and it's amazing for anxiety, for post-traumatic stress, for pain, phenomenal for pain, for severe depression, and can help the body recover in numerous ways. I don't think it's a standalone agent by any means, and it's very limited and can have some side effects for sure. But it can be very useful as well for many people.
Okay, excellent. So I just want to acknowledge that it's highly unusual for us to speak about an individual patient, but I work with Natalie daily, day and night sometimes, and she's specifically asked for that, so this has been with her permission. And I also wanted to acknowledge Natalie because everything she does for herself, she's got such a huge heart. She's fighting also for every one of you. If you're watching this and you're sick, the reason she wanted this highlighted is to offer you hope and education. So Natalie, thank you for all you do on behalf of others. Now, back to a few more general questions, if that's okay. What are the challenges with diagnosis and testing for tick-borne disease patients or tick or other vector-borne?
Well, there's a lot of challenges. One, it's the organism, if we're talking about Borrelia, whether it's Borrelia burgdorferi or relapsing fever Borrelia, which is another species that seems to be more and more common in Australia, there's not a lot of organisms in the body, comparatively, microbiologically speaking, so it's hard to find those organisms themselves. And then so there's these direct tests which are looking for the organisms, and it's hard to find. And then there's indirect tests which look at the body's awareness or response to those organisms, whether you're using T cells or B cells that make antibodies. The Borrelia burgdorferi doesn't actually elicit a very large antibody response, especially later in disease. Maybe in early disease, there may be a nice brisk response for about 60% of people, but which leaves 40% that it doesn't. But in later Lyme, if you're looking for antibodies or the body's awareness of immune cells against the infection, it's very uncommon to find a huge amount of them. And so the problem is that the testing strategy that's now in place is called a two-tier system. The first tier, one has to often get through in order to get to the second tier. The first tier is based on the quantity of antibodies. You use what's called an ELISA test or an IFA immunofluorescence assay test that is measured, that measures the quantity of antibody, the total antibody against the infection. And Borrelia doesn't inspire or elicit a very large antibody response. And so most people never get to the second tier, which is the immunoblot or Western blot, which actually looks at specific antibodies, but doesn't actually look at the quantity of them after it gets to a certain threshold. It's more of a qualitative test rather than quantitative, and it's much more specific than that first tier test. So the tests, there are some very good tests, and I think that when one combines the immunoblot or Western blot, which are the antibody tests, and doesn't really pay attention to that first tier and can go straight to that second tier test. The tests are very specific, and their sensitivity isn't terrible. It's better in earlier disease, worse in later disease, and it's definitely worse in children who are born with Lyme. Their body sometimes doesn't recognize the agent as foreign. But if one combines T cell tests and B cell tests, these antibody tests, and direct tests such as DNA or PCR testing, and hopefully in the near future RNA testing, and even farther in the future accurate culture testing to actually look for the organism growing. I think that we're close. I think that there's definitely some exciting technologies on the horizon. I think that the diagnosis part, if you look the right way, you're going to get at least 90%. You're going to find at least 90% of those people. It's just you have to look correctly. You have to look right, and you have to look at. One of the problems is that even the immunoblot or Western blot, there's different proteins on the surface of the organism, and it's the antibodies that look at those various proteins on the surface. Those proteins kind of look like sticks coming off the surface, and in early Lyme, there's different protein, there's different antigens, there's different proteins that are there than in later Lyme. And the tests are only generally made to look at those early tests. It was the tests were made for surveillance purposes. They were made to see in a very general way how many cases there were in whatever state in America at the time. Was how they did it. And it wasn't meant necessarily for diagnosis of a specific individual. It was very population-based tests that they dumbed down a little bit. But in later Lyme, in someone who's had Lyme for more than a year, there's different antigens that these organisms are expressing. These organisms are very smart, very hardy, very survivable. And they do that from switching what their protein, what their clothing looks like, as it were. And so it looks different to the body later than it does earlier. And so if one can take that into account, the tests are not terrible if you're looking at it right. But if you're just doing what in our case, the Center for Disease Control tells us to do, which is the 2-tier ELISA followed by Western blot, we're going to miss of patients who've been sick for more than a year, we're going to miss at least 70% of those cases. Has been my experience. The literature is variable, but I would say 70% is what we're going to miss if we're just doing ELISAs, the 2-tier testing, and we're not incorporating DNA testing, we're not incorporating T-cell testing. So the diagnostic challenges is really about communication. And thankfully, the patients all over the world have been amazing, because it's the patients that now know this. It's become quite a community, and it has been, in a sense, like the HIV movement. We don't have people mobilizing on the streets in the hundreds of thousands like we did in the 80s, but we have quite a remarkable community that are trying to teach the doctors, but the doctors aren't listening right now.
What is best practice for diagnosis?
Best practice for well, that's a hard call, because there's the clinical picture one has to take. So it's really, I think the best practice is to listen to the patient, but within that rubric, looking at the likelihood of tick exposure, looking at considering travel, considering animals, considering the possibility that one had exposure to a tick. Now we know that there's there's theories about other forms of transmission, but just talking about ticks here, knowing that people do travel, that people do spend time outdoors, that people have pets, that people have loved ones that have traveled, for example. So considering the likely possibility of tick exposure, and looking at a constellation of symptoms, if there's several symptoms, body systems that are affected, one should consider it. I think all cases of multiple sclerosis should consider and at least do testing to rule out a spirochetal infection. I think that in many other conditions that it should be ruled out, if nothing else. So it's keeping an open mind about the possibility, I think, is the number one best practice. But within that, I think doing a Western blot or immunoblot that includes some of the proteins that you find in later Lyme, and then if that test is negative, possibly doing DNA testing. And sometimes what's curious is that what we'll do in our practice and have found to be quite effective is sometimes we'll even use a diagnostic challenge, as it were. So we'll do a challenge test. One of the ideas being is that these organisms sometimes can be, or oftentimes can be, inside of our cells, not in our bloodstream where the immune cells are. So if they're inside our cells, we need to get them out. So if we could kill them, for example, some of the pieces of the organism will come out of those cells into the bloodstream. Then the immune system can have time to recognize it if it's not hiding. So we'll use sometimes an antimicrobial challenge for a few days, and then at the right time, then repeat that immunoblot or Western blot. Sometimes we'll do the DNA testing in conjunction. Sometimes we can do urine testing that's provocational if we kill some organisms, if we think that they're there, with informed consent and all that, knowing the risks and benefits of the treatment. Then it's not appropriate for everybody, but the other part of the best practice is for the practitioner to work with the patient on an equal footing, or in a collaborative way, at least, if not on equal footing, at least collaboratively, and let the patient decide that do they want to maybe take a risk with some antibiotics in a short, controlled way, if that means that it can pull organisms out into the urine where then we can see them. And so I think best practice is listen, collaborate, and then do the proper testing.
Fantastic. And you've brought up a good point there about, like, I believe that people have a human right to best practice healthcare, and that people with multiple diagnoses, many diagnoses that are out there where causality is unknown, also have a human right to have Lyme included as part of their differential. So I had Alzheimer's, dementia, lupus, sarcoidosis, and fatty liver, and all these sort of random things that were identified, certain things that went wrong with my body. And Lyme wasn't included as part of my differential diagnosis without me fighting and knowing something was wrong and looking worldwide. So what other diseases do you see coming into your practice that you right away go, well, we need to include Lyme as part of your differential?
So ME/CFS, the myalgic encephalomyelitis, definitely. Mold illness, we get quite a few patients with mold illness, and we also look at Lyme. Fibromyalgia, rheumatoid arthritis, any non-traumatic musculoskeletal disorder. We're looking at other causes, such as Lyme. We're also looking at, with patients with severe profound depression, we're looking at patients with bipolar disorder, patients with severe anxiety disorders. We're looking at major hormonal disorders after neoplasms have been ruled out, of course. And I think that one has to consider Lyme in so many different diseases. In dementia, of course, we're looking at Lyme. In almost all of the neuromuscular diseases that aren't direct genetic basis, we're looking at tick-borne diseases as a possible cause. We're not always finding it. Of course, we need to play devil's advocate. There's so many naysayers, and there's so many people out there who are saying that we're over-diagnosing Lyme, or that we're seeing it wherever we look, and that's not true. We have to take that viewpoint that we're going to look at everything, and Lyme will be one of those things, but we're not going to jump to Lyme as the causal agent all the time.
And what do you see presenting in kids? They're sort of an under-recognized segment of.
We see anxiety quite a bit. We see motor tics. We see listlessness and poor school performance. We see a loss of previously met milestones. Of course, we see pain. We see arthritis. We see all sorts of things. Primarily, it's neuropsychiatric symptoms that we're seeing.
Yeah, it's very. I've seen that here in this country. It's even more sad when the kids are in trouble. So, is there anything that I've missed asking you that you think is really important to highlight for the picture for Australians that are sick and their family and their doctors?
That there's hope out there, and that there's treatments that work most of the time. There's when you're using just antibiotics, it's going to work a lot of the time, and when you incorporate other modalities and you're open to sometimes non-evidence-based modalities, that the treatments are going to work most of the time. Sure, there's going to be times when nerve damage is so severe that someone who has a neuroborreliosis or neurologic Lyme that's presenting as Lyme or ALS, sometimes we're not going to be able to stop repair the damage that was done. But many times, or most of the time, we'll be able to arrest the progression of it. So the number one thing is that there's hope. The number two thing is that the patients have to advocate for themselves, and their families have to advocate for the patients who can't advocate for themselves. And the doctors need to be retrained. And there needs to be more dialogue between the people who believe that there is no Lyme or that these aren't manifestations of Lyme, and those others who do understand the breadth and scope of this disease. And so the people need to get together and communicate more. And there needs to be more funding, because the money's going to drive it. The money's going to hopefully drive it in the right direction. But at the same time, it needs to be earmarked, the funding needs to be earmarked correctly. There's a prominent university that received quite a large grant to study Lyme, and the donors had all well intentions to look at Lyme as an active as an active infection, but the funding was misdirected and went to just looking at autoimmune mechanisms of disease. And so the funding was, in a sense, partially wasted, I should say. While the research may be useful, it's not going to get to the heart of the matter. So I think that if people are going to be funding universities or different projects, that they need to be very careful in how they have the funds earmarked certain ways. And then I think holding people accountable and who are unable or unwilling to consider alternative viewpoints. I think that at the end of the day, it's all about patients getting better. And if we can help them get better with non-antibiotics, I'm all for that. And so as long as we keep the true goal in mind, then, and we're held accountable to that, that's probably the best thing that we can do. Of course, that involves governments and having governments really explore the extent and scope of this, and addressing it at the highest levels.
And so what would your call to actions be to government or health policy makers in regards to the perpetuating the myth that Lyme is not endemic in Australia, the only country in the world, the only continent in the world that makes that claim?
To listen to all the stakeholders and to look at the literature. There was animal studies in the 1950s. They found it in the 1950s. And there's been numerous animal studies until the 80s, and then the human studies since the 80s. It's there. It is absolutely unequivocally there. Both Borrelia sensilato, Burgdorferi sensilato, as well as relapsing fever Borrelia. We know it. And the data, we keep seeing similar percentages of patients who come in with similar symptoms in study after study. So if you don't believe that I'm telling the government, then go test the ticks. Go do numerous tick studies and see what's inside those ticks.
Thank you. And we also currently are in a situation with this politicization and denial, is that the doctors that are doing the right things by patients have been shut down gradually by the regulatory bodies. Now we've got at least 16 doctors that have been either restricted from doing the right thing by Lyme patients, or completely deregistered. On previous videos, I called them in the trenches, which might not be accurate. They're on the front line, and the ones that are being ethical in their healthcare. What's your words for them today?
It's hard because it takes a courage to do that. And then when we lose one of the docs there, then the next person may not be so courageous. And so it takes then that much more courage to stand up for what's right. And so it is the same kind of courage that one needs in the face of racism, for example, or many of the other aspects of life that in which we need courage to speak against authority, truth to power. But at the same time, I think that doctors need to band together, and practitioners need to band together. I think people across different disciplines need to band together and work together. I think that the social justice advocates, social justice lawyers, I think need to work with physician groups and to work with advocate groups and to work with, I think if one also could study, I really think that if one studies the socioeconomic political economy of Lyme from the 1970s, and one can really look at it from a multidisciplinary fashion, not just from a scientific standpoint, but to actually look at it as a socioeconomic phenomena, that we can understand how these impressions came to be.
And one last question. you're talking about that there needs to be a dialogue, and there actually in the last, say 3 years, oh no, probably since 2012, the dialogue was started. But from my perspective on watching that and having lots of hope over the years, what I'm seeing is that it's just like they're ticking a box. We've done that, we've listened, but the action hasn't followed. That the denial of the people who actually have experience like yourself of getting 75 to 80% of their patients better, and the multidisciplinary approach right now that's planned, or the draft approach, isn't looking for people experienced in treating Lyme's, professionals experience. They're sending them out to all the practitioners that have denied care for decades now. So how important is it, you're talking about that human justice and the legal justice experts, how important is it that they actually not only listen, but take action and give credible weight to those who have the experience of helping patients?
Well, where we've worked on that here, there's been some very, very supportive Congress people and senators and other people at different levels of government. And so it's rallying around those people. Here in America, it's about votes and getting these folks reelected. And so that's one way that I think we can encourage these people to stay the course. But it's so important that if they're going to support what we need, then we need to support them as well. And I think it's many of them do have skin in the game. They have family members or such that have been bitten and been afflicted. But in the case of those who don't, it's presenting the evidence and presenting the numbers, showing the numbers of people who will support them if they're being supported.
And what's in your heart to leave people, either those sick, their families, their doctors, with today?
That there's some brand new treatments out there that are sometimes it's not going to work for everything, but there's some amazing treatments that might be much easier to tolerate, that might be much quicker, that it's not going to be 10 years of treatment, that sometimes 9 months, 6 to 9 months, we might be able to knock out a lot of these cases of Lyme and Babesia. There's some fabulous stuff that's happening. There's a lot of people who are interested in this disease. It's becoming unbelievably common as far as people aware of it around the world. There's so much international connection. Doctors from all over the world are coming together. Patients are coming together. This is it is somewhat of a global movement to put this disease on the map and to eradicate it. And so things are really happening. And the more people can help at an individual level, the quicker this is going to work.
Dr. Harris, thank you so much. And for those of you that are losing hope right now, please remember that there's been many times in my journey with Lyme that I thought this is it. And I had, a significantly serious suicide plan, and something was around the corner that I didn't know there. So anytime you go there, know that there's something around the corner and there is hope for you. So reach out to us. We have the Lyme support program, support.lymedisease.org.au. If you're feeling mental health challenges, or if you're not okay, reach out for us to help. So thank you, Dr. Harris. I really appreciate your time today.
Thank you very much.